Assalamu alaikum. My name is Anusha Smile and my roll number is EP1770015. The topic of my presentation is geriatric drug use, and my subtopic is osteoarthritis. First of all, what does geriatric drug use mean? It means the use of medications in elderly people or elderly population. According to WHO, people 60 years of age and older is 650 million and forecast to reach 2 billion by 2050. Persons ages 65 years and older constitute 13% of the population and purchase 33% of all prescription drugs. Aging affects rate of absorption and hepatic metabolism. It also decreases the ability to regulate blood, increases gastrointestinal sensitivity. Brain and nervous systems are also sensitive. Increased use of medication is one of the reasons for complications. Adverse drug events are responsible 5 to 28% of acute geriatric hospital admissions. Osteoarthritis. Osteoarthritis occurs when the cartilage that cushions the end of bones in your joints gradually deteriorates. Osteoarthritis is also called degenerative joint disease or wear and tear disease. Its symptoms slowly develop and worsen over time. Symptoms of osteoarthritis includes pain, stiffness, tenderness, loss of flexibility, grating sensation, bone spurs, and swelling around your joints. Risk factors of osteoarthritis include older age, sex, obesity, joint injuries, reported stress on the joint, genetics, bone deformity, certain metabolic disorders. Diagnosis of osteoarthritis includes imaging test and lab test. In imaging test, it includes X-rays and MRI, while in lab test, it includes blood tests and joint fluid analysis. Treatment strategies include medications like acetaminophen, which is the drug of choice and is used before NSAIDs in osteoarthritis. The next drug of choice is NSAIDs, while the next is duloxetine, that is an antidepressant and is also approved to treat chronic pain, including osteoarthritis pain. Therapy includes physical and occupational therapy. In physical therapy, it includes exercise to strengthen the muscles around your joint and increase your flexibility. It reduces pain. Regular gentle exercise that you do on your own, such as swimming or walking, can be equally effective. Occupational therapy includes it helps to discover ways to do everyday tasks without putting extra stress on your already painful joints. For instance, a toothbrush with large grip could make brushing your teeth easier. Case study. A 71 years old retired school teacher has been suffering from osteoarthritis of his hands for 5 years. He is active older adults who enjoy volunteer work at the local hospital. He presents to the geriatric clinic with increased arthritis pain, which is uncontrolled by his current pain medications. He also complains of increased heartburn and gastric reflux symptoms. He also takes several other medications for his diabetes, hypertension, hypercholesteremia, and GERD. Case study current medication include glipizide 10 mg QD, verapamil sustained release 240 mg QD, atorvastatin 10 mg QD, famotidine 20 mg BID, docustate sodium 100 mg BID, and ibuprofen 200 mg QID PRN. What modifications can be made to his drug regimen to better control his arthritis pain and minimize side effects from his pain medications? Case study reveals that he has tried acetaminophen without much relief of his pain. He has been prescribed celecoxib and tries it for several months, but his pain continues and he is still experiencing GI distress. What other pain medications options does case study reveals? Soap notes. Patient clinical profile is his age is 71 years, his gender is male, and the diagnosis is hand osteoarthritis. Present complication is hand osteoarthritis, heartburn, and gastric reflux symptoms. History of presenting complaint is he tried acetaminophen without much relief of his pain, celecoxib, and tries it for several months, but his pain continues and still experiencing GI distress. Medical history includes osteoarthritis, increased heartburn, GERD, diabetes, hypertension, hypercholesteremia. Medication that he has been taken is glipizide, verapamil, atorvastatin, famotidine, docustate sodium, and ibuprofen. Objective: Management of osteoarthritis and complication it is causing. The plan for the management of osteoarthritis that we have been using must be something other than acetaminophen and celecoxib, because these two medications he has been using and are not effective. Acetaminophen is basically the drug of choice for mild to moderate arthritis pain for elderly with reduced hepatic function, or those who drink more than 2 alcoholic beverages a day. The recommended maximum daily dose is 2.5 grams per day. Acetaminophen is preferred over NSAIDs in the elderly because of its lower renal and GI toxicity. Ibuprofen may be contributing to increase GERD symptoms and to his hypertension. That's why we have been using non-acetylated salicylates such as salicylate can be used if acetaminophen does not provide adequate pain relief. Compared to NSAIDs, non-acetylated salicylates have fewer renal and GI side effects. For moderate to severe chronic pain due to osteoarthritis, the topical analgesic capsaicin has been shown to provide temporary pain relief. However, capsaicin requires multiple daily applications for effective management of pain, and optimal efficacy takes 4 to 6 weeks of continued use. We cannot prescribe him glucosamine because he is already diabetic, and glucosamine increases blood sugar. That's why we cannot recommend it. So another option that we are left with is codeine and tramadol, that are weak opioids and have ceiling effects and generally do not provide adequate analgesic. The use of propoxyphene should be avoided in an elderly patient because it has limited efficacy and risk of neural and cardiac toxicity. Mepridine should also be avoided due to CNS side effects. He should be started on the lowest dose of the short acting formulation on a scheduled regimen and counseled on the side effects. Constipation may be due to verapamil, or maybe elderly are also at increased risk of constipation due to age related induced bowel mobility. To prevent opioid associated constipation, prophylactic laxatives and stool softeners should be used at initiation of opioid therapy. Bulk laxatives are inactive and should be avoided. For verapamil constipation, he has already been using dose. He is already using docusate sodium, so we'll counsel him to drink adequate fluids to avoid constipation. And since he has been using stool softener, so we'll not recommend any other stool softener. Here are references from I have taken the case studies and other information. Thank you.